We really went from the 1990s until really early 2020s in kind of a hormone desert. New HRT starts, and they're all wanting it. You have to almost convince them if they don't want it, right? Everyone wants it because it's sort of being seen as like the fountain of youth. We really treat the symptoms, and that's what we keep bringing it back to, is creating this collaborative approach and customizing the approach for you with your HRT.
This is the Transformational Life Consulting Podcast with Deepa, Grandon, MD, where Christians like you get the practical support and tools you need to build your spiritual, mental, and physical well-being, and to guide you on your journey to health and wholeness based on evidence-based science and God's Word. I am your host, Dr. Deepa Grandon. Welcome back to another episode of Time to Transform. So for our returning community, it's so good to have you back in this space of growth. And for you who are joining us for the first time, a very special welcome to you. So a little bit about our mission here. It's pretty simple, but I personally think it's very profound. We would love to provide you with insights that are not only meaningful, but applicable. All right, because we truly believe here in Time to Transform that true vitality isn't like in a single habit, but it's more an intentional evolution of your spirit, your mind, your body. And today's conversation, I would think, is a perfect example of that type of Trinity in action. So we are actually standing at a massive crossroad when it comes to women's medicine. So for almost 20 years, there has been a cloud of caution that has hung, especially over hormone replacement therapy. And unfortunately, that left millions of women just having to white-knuckle their way through their mental and physical issues that come with menopause. And thankfully, the tide has officially turned. With the landmark 2025-2026 FDA modification and long-awaited reassessment of the Women's Health Initiative data, the medical community has finally acknowledged what the timing hypothesis has suggested for at least a decade. Hormone replacement therapy is not just about bone density. It's also so important for neuroprotection, cognitive longevity, meaning the mind and the health of the mind. So women everywhere now, it's no longer, hey, you just have to grin and bear it. It's what happens with aging. And thankfully, many women were demanding answers about brain fog, premenopausal depression, and the fluctuating estrogen levels that really, really dictated quality of life. So thankfully, through this evidence-based revolution, we have secured one of the most respected voices in the field. So I'm truly grateful for our guest today, Dr. Krista Olson. She is a powerhouse when it comes to women's health leadership, and she is a specialist at the forefront of hormonal optimization. Dr. Olson is the physician president of the Obstetrics and Gynecology Associates, and she is a distinguished board member of iHealth. So she had her medical foundation from the University of North Dakota, specialized residency training at University of Minnesota. She is dual certified by the American Board of Obstetrics and Gynecology and the American Institute for Ultrasound and Medicine. In 2024, she earned the distinguished prestigious designation of Menopause Society Certified Practitioner, and that places her in an elite tier of clinicians who are recognized for their mastery in midlife medicine. But what really sets Dr. Olson apart is her holistic approach to the whole woman. So as a certified physician coach, she doesn't just treat symptoms. She works with patients and physicians all over the nation. She helps to dismantle the mental barriers that people face to health. She helps them build a roadmap and really, really, truly can radically transform lives. So her coaching background has, really helped with her engagement with patients on a much deeper level and has helped them to navigate fear, misinformation around HRT. So you can actually, when you meet with her, you feel like you're making this confident, life-changing decision. So, Dr. Olson, it's truly a privilege to have you here. Before we dive into the clinical data regarding estrogen in the brain, we'd love for our listeners to get to know you better. You've had a pretty incredible journey from Scandinavian studies to leading major medical boards. Can you tell us a little bit about your why? What was that moment which drew you so deeply into women's health, and specifically, how has your background as a certified coach changed the way you engage patients, and especially the ones who are struggling, say, with the transition into menopause?
Well, first of all, Deepa, thank you so much for the kind introduction. It felt very, very generous, but thank you so much. And for inviting me onto your podcast. This is quite a pleasure to be here. And as you've noted on multiple levels, really talking about my passion. It's interesting when you ask sort of that roadmap of how I got here, right? Is I've never been one to be much of what we call an external locus of control, meaning just allowing where the wind blows. But I guess when we start looking at it, I've kind of gotten to where I have currently and professionally by continuing to follow my passion and responding and pivoting and really taking concerted evidence-based steps forward into elevating my practice and responding to what my patients need. And so that's really truly where I got to where I am today, along with responding to what I felt like I needed as well for my own well-being and my own care. So currently, like you said, I'm a full-time practicing OBGYN. I do quite a bit of minimally invasive surgery, but I was running, I've been practicing for 17 years. And so you start aging with your patients, right? Mm-hmm. So really running into this dichotomy of inheriting a lot of patients that were older than I was from partners that had retired, and they had had them on HRT since the 80s and 90s. And I thought, oh goodness, what do I do? I'm keeping these women on this thing that's going to, cause them harm. And really trying to understand when we hadn't relooked at the Women's Health Initiative again, because that's when I trained in med school, right? This was our epidemiology class, was the Women's Health Initiative. And really then answering and pivoting to know, how can we do this? How can we do it better? And then we'll talk a little bit about my perspective of patients, as I always call a bit science-minded. We're not single variable equations, but we're ecosystems. We're not even multiple variable equations, really. So looking at how do we look at, as you said, the whole of the person and the patient and ourselves, and really saying, what is it that we need and how can we pivot, and how does each single little step or intervention that we make really change that entire ecosystem. And so that's why I went on to be obesity boarded and menopause certified and life coach, to kind of fit all those pieces together in a daily practice.
Okay. Yeah, that's amazing. Yeah, I think all of us, we kind of evolve with our experience over time, adding different certifications based on what we think will help our patients the most. So that kind of transition and history makes total sense. So when we come to the evidence of hormone replacement therapy and mental health, what does the recent data tell us about that relationship, especially during menopause? Because we've seen a surge in women asking about hormone replacement therapy, especially from mood symptoms. So what's driving like this renewed interest, and what does the evidence actually show us about estrogen's effects on depression and anxiety during the menopausal period?
So interestingly is, let's kind of go back, if you don't mind, a little bit historically, so we can kind of set the playing field. So prior to the 1990s, there was this idea, kind of a little bit of antiquated idea now when we look at it, of, hey, I felt decent in my 20s and 30s. Boy, I had a rocky decade, and now I'm having a lot of symptoms in my postmenopausal phase. So the solution that many of us as providers, looking at kind of that observational data, was, gee, the thing that's missing is hormones. So let's give you hormones, right? So that was back in the 70s, 80s, when we came up with conjugated equine estrogen. We came up with different forms of progesterone, and we would give these to women, and gee, they did tend to feel better. Many of their symptoms, and we'll talk about sort of classic symptoms, tended to improve. Well, then, we're always on a conquest for data. So in the 1990s, actually, it's starting before then, it was a large data collection set, with something called the Women's Health Initiative. And so that's where they took this large group of women and they said, hey, should we do hormones or not? And is there a benefit or is there a risk? And they really they really said, hey, there's a significant risk. So in 1990s, we sort of pulled all of these women off their hormones saying, oh my goodness, we're going to give you breast cancer and we're going to give you blood clots and all these terrible things. Let's pull you off of it. And so, Dr. Grandon, we really went from the 1990s until really early 2020s in kind of a hormone desert, right? Really leaving women to say, hey, this is a phase in life. You'll get through it, deal with it. And then at that point, there was a relook at the Women's Health Initiative, only to realize that we had overemphasized the original risk in that study. So, gee, those hormones weren't as risky as we thought. And now actually we had more hormone options and we could dose them differently. And so that's what really got the FDA moving on wanting to remove that black box analysis. So that sort of sets the stage as to why we're even here today and how we're even having that conversation. What I think is great is the parallels between menopause, hormone replacement therapy, and obesity currently. Is they were these medical conditions, essentially chronic, right? Because once you enter into it, obesity is a chronic relapsing remitting. Menopause, once you're perimenopause or menopausal, it's a chronic state. And we had no solution. But now that we have this evidence and data for both symptoms, it's now we have options to treat. The thing that we're also in is kind of a bit of a sticky situation because our options to treat are being met in the free market with uncontrolled social media. And so it's very hard for those of us, even with MDs, let alone even those who are certified in the condition, to know exactly what's right, what's wrong, how should we treat. Some things seem to work, some things don't. And I will put an asterisk that I think we're continuing to evolve, as we'll talk about the data that we have right now, both hard, concrete, randomized control trials and observational data. They're butting head to head. So there's more to the story. Okay, so that was setting the stage. I got a bit long-winded, but I think that helped. But to talk a little bit about mood, and mood in the perimenopausal episode with hormones, it really is variable in what we're seeing in research. When we look in the research, there's really only reported in research a small to moderate improvement in mood in the peri and postmenopausal period. And actually, in most of the studies, it's almost similar to placebo. What's interesting, though, is when we start talking observational data, meaning when we've gone back and asked patients how they feel in large cohorts or large groups, or even one-on-one in a clinic setting, it's a much different story, right? These patients are having really a much improved experience. Now, we're also seeing the improvement more when they are more naturally occurring forms of estrogen and not synthetic forms. And we're not seeing as much benefit with the addition of progesterone. And we can talk a little bit eventually about how we dose hormones. But we're not seeing as much benefit with the progesterone. But some observational data actually says maybe the progesterone is helping. And we think that becomes part of that ecosystem or that multifactorial approach of the estrogen maybe helping with some other symptoms that may contribute downstream to improved mood, which we can get to.
Okay. Yeah, that would be great. Because for me personally, and also many of my patients as well, there is definitely a difference between the oral versus the transdermal estrogen. And because I travel so much,
Okay.
with my different stages, the mood was something that I really noticed, and it was pretty dramatic while transitioning stages and getting on the transdermal. While, yeah, it's great. Like, I don't have hot flashes anymore, but that deep seated feeling, just the down mood and brain fog, it was a game changer. So I can totally relate to what you're saying, because a lot of times with research versus what we see as clinicians, it almost takes 10 years before
Totally.
the research can catch up,
Yeah. So I think we're all kind of living in a research lab currently, and it's going to be very interesting what our story is or what this conversation will be 10 years from now.
Yeah. And when we're talking about the timing hypothesis, how do you counsel patients about the timing hypothesis when it comes to the hormone replacement therapy and mental health benefits?
Yeah.
Yeah, because we have like now evidence that shows, when HRT is initiated actually matters, not just for mood, but also cognition. So can you explain what this means for women in their late 40s versus 60s?
Yeah. So let's kind of, to speak to the whole audience, let's first pull it back for a second and really talk about what is HRT,
Okay.
what are options for women, how they can do it. And then let's talk a little bit about physiology. So HRT, hormone replacement therapy, it's giving you some form of a hormone at some time in some preparation. Now, for most females, we've got all kinds of hormones going around in our body, but typically when we talk about hormone replacement therapy, we usually talk about some form of estrogen and plus or minus some form of progesterone. Typically, when you're taking estrogen, if you have a uterus, if we don't give you some form of progesterone, we're going to increase your incidence of uterine cancer. So if you have a uterus, we actually have to dose both. There's some different preparations that we'll talk about, some non-approved FDA things that we can talk about. Now, coming into the playing field too, many of us will start talking about testosterone as well, which is another benefit. And that we're going to talk a little bit about the various forms of estrogen, how we can take it, and how there may be some downstream effects. Testosterone is not currently FDA approved for women. However, it just sat in front of the FDA board this year. We're hoping within the next year to year and a half it will be FDA approved, but many of us will use it off label. Okay, so we now know we have estrogen, progesterone, testosterone, the majority of hormones. We're not going to get into all kinds of other hormones like cortisol, and we'll mention them off the cuff a bit. So if we're doing estrogen, there's a few different forms of estrogen. I'm not going to go through all the different subtypes of estrogen. I'm just going to go through, for generalization, the different ways of taking it. So estrogen, you can either take in an oral tablet, and that's kind of what we traditionally had for a while, or you can take it in a transdermal patch. The differences are risk. So what we know is when we take things orally, the way our body metabolizes it is it can go through the liver. And when it goes through the liver, it affects how the liver works, and it affects everything downstream from the liver. So when we take oral estrogen, it can sometimes affect our clotting factors. And so that's why we like to avoid oral estrogen. That was one of those fears for many years, is that increased risk of blood clot, stroke, heart attack, right? So in general, I like not to use oral if I can avoid it. And we like to use transdermal. This speaks to kind of your experience. Usually when you do transdermal, you get to avoid what's called first pass metabolism. And that, again, will allow your liver to function differently and will not have as many downstream effects. Now, what's interesting, if we think about it too, if you think about metabolism, when you take something orally, you're going to metabolize that at a different rate throughout the day, and your levels are really going to increase and decrease throughout the day. Plus, it's going to throw off everything downstream in your liver a little bit more, right? Clotting factors and such. What's also interesting is in the transdermal form, you're going to get more of a steady, constant state of your hormones. So therefore, patients usually have a bit more of a physiologic response, meaning they feel more innate to what their body would feel. Secondarily, when you absorb medication, it doesn't go through your liver the same way. So it's not going to have the same clotting effect. The other piece, interestingly, that we see with transdermal estrogen is it also affects This is where it gets a little biochemical. Your sex hormone binding globulins, which are going to allow, kind of think about it like allowing some of your hormones to be free in your bloodstream and not. So it's going to affect all kinds of other hormones like testosterone and things in your bloodstream. We also know in transdermal estrogen is it affects some of the downstream neurotransmitters, which may speak to a piece of the mood as well. So, okay, to wrap it up, with estrogen, we have oral and we have transdermal. Most of us will try to do transdermal forms. And progesterone, we've got a few different things. Most of us go with oral. There's a few different forms of oral that have pluses and minuses. Non-FDA approved is we can protect uteruses with progesterone in the IUD. It's not FDA approved, but it is an off-label. It won't give you systemic benefits. So that's kind of a conversation for another day. If a patient does not have a uterus, we don't have to be considerate of progesterone unless we would like some of the side effect benefits of it, which we will sometimes use. So there's the basis of the forms of HRT. So if you came into my office, right, and you said, hey, I am reading all about HRT. And by the way, my social media algorithm is sending me everything HRT, right? And this is all my friends, that's all they're talking about. What do I do? Right? And so what we do is we have a conversation. We have a conversation about data and our lived experience. So there, the formal diagnosis of menopause, if you were to open up a medical dictionary and read it, it's 12 months without a menstrual cycle. Well, it's a bit of an antiquated diagnosis because we now have endometrial ablations and hysterectomies and IUDs and PCOS and all kinds of things that can get us from stopping to have a period. But that doesn't necessarily mean our ovaries have stopped working, right? So oftentimes to truly get that diagnosis, we used to just check something called FSH, which is a hormone that stands for follicle stimulating hormone. We now know the phases within about 2 years of that approach to that last menstrual cycle can really swing our FSH high and low and vacillate it quite a bit. So we typically will want to look at it in conjunction with the estrogen level in your body. So I always explain it to my patients is when you're getting closer and closer to menopause or menopausal, FSH comes from our brain. And so it makes our ovary work. So if our ovaries are working nicely, they can just have a really nice, quiet conversation, meaning the FSH is nice and low. If the ovaries are just barely hobbling along and we can't get them to do a lot, that FSH from our brain really needs to turn up the volume and speak very loudly to our ovaries. And so that FSH climbs into more of a peri-postmenopausal range because it's trying to work really hard in getting that ovarian function to work. So we know if the FSH is really high and our estrogen is quite low, because estrogen primarily, there's other forms in our body, but primarily comes from the ovaries. If that's low, that's indicative that we are very near or after that last menstrual period. So we talk to the patients. Are you still having periods? Okay, is there a reason you're not having periods? We should maybe check your estradiol and FSH. And that gives us kind of a biochemical of where are we. But we also have the conversation about what are you feeling? How is this going? What symptoms are bothering you, right? And menopause / perimenopause really is a combination of any and or all of, hold on tight, hot flashes, night sweats, brain fog, joint pain, palpitations, skin changes, mood changes, dry vagina, irritability, right? I can go on and on with all a sleep dysfunction, all kinds of changes. And some women, I will say you're a magic unicorn if this happens. some women don't have any symptoms. Some women have all of them. Some women are really plagued by just a few of them, right? So if we think physiologically, what happens is really before puberty, we have minimal fluctuation in our hormones. And then puberty comes and there's fluctuations all over the place. something called our HPA axis, which is basically the central computer between our brain and our ovaries, starts to figure out how to work. So puberty is these few years of that whole system figuring out how to work. And that's why we feel kind of so out of whack, right? And then all of a sudden, our ovaries and our brain are like, hey, we got this. We know what the job is. And we figure out how to ovulate almost every month for most of us, if we're not on hormones or don't have other underlying endocrinopathies. So then we go along for 20, 30 years with this nice, predictable hormone rhythm, right? And then onsets perimenopause. I always say about 8 to 10 years before the actual last menstrual period. I joke with my patients, I call it purgatory. But that's when these symptoms start, right? And so what it is it's almost like a mirror to puberty. We're going from having a nice, predictable vacillation into hormones. I always say we move from the green hills, the green rolling hills of hormones that we know what we're doing and we can navigate life, to all of a sudden we're living in the Swiss Alps of hormones. Meaning one moment our estrogen's up and then our progesterone's up and then our testosterone's down and it's all over the place, right? And enter stage right, all of our perimenopausal symptoms, right? So that's really, really where it starts, Deepa, is having that conversation of where are we biochemically? What's kind of our medical story? Is this a PCOS? Do we have ovaries in? Like, let's set the sights. And then let's try to define, are you perimenopausal or are we postmenopausal? Because I always tell people menopause is really one day. It's 365 days after your last period. Everything before there is premenopause and everything after that is postmenopause, right? So really the thing that is different in it is defining it, but the most important, and where we currently have data, which we'll get to, but to me, what really matters is like, how was your lived experience? Can we help you to feel better? Right? And so that's where we start cultivating and creating a customized approach for the patient of, yeah, if you're perimenopausal or you're not completely postmenopausal yet, but this is really taking you for a ride. Let's treat you. What's bothering you most? And we start building a plan for that.
Yeah. So age is just the number. It's more about the biology.
Yep. We do approach the premenopause oftentimes with a different dosing and sometimes different approaches, but again, customized to the patient. Because in that phase, your ovaries are still trying to occasionally ovulate. And so sometimes, unless we're giving it to them in a phasic approach or protecting their uterus, we might kind of get into some dysfunctional spotting, which patients don't always like. The postmenopausal approach is more cut and dried. And so that's a bit more easy to approach in like a prescribed way.
Okay. So in your own practice, I'm sure have patients just come in with all kinds of fears because they, like you said, social media is a huge information machine that they get a lot of their data from. So what's the disconnect between the patient's perception and clinical reality regarding the HRT risks? And now, in spite of the Women's Health Initiative data, many women, they still fear the HRT. How do you address these concerns while also discussing mental health benefits?
Yeah. So what's interesting with that is up until about 2 years ago, to talk to a patient about HRT, they would look at you like you were trying to cause significant harm to them, right? Because that's what we were being told, right? And now I probably see, a dozen plus new patients a week for new HRT starts, and they're all wanting it. You have to almost convince them if they don't want it, right? Everyone wants it because it's sort of being seen as like the fountain of youth, that it's going to solve everything in their life. And so it's really sitting down with patients and again, having the conversation almost that you and I have had today. Let's define it. What is it? Where are we? And what's bothering you? Then we sit down and we deconstruct, right? Is it more primarily mood? Is it hot flashes, night sweats? Is it dry vagina? Is it irritability, right? And then we start talking about how do we want to approach it? And what should we start treating first? Oftentimes it's that they have one to two, it's usually not the whole basket, but one to two things that they really want help tackling. And I always tell them it's rare that I'm going to hit the perfect thing the first time around. Oftentimes we'll give a try, right? We'll say, hey, let's start you on the 0.05 transdermal estrogen patch and 100 of progesterone orally. And I always say it takes about 4 to 6 weeks to get serum stable. Let's see you back at that time frame. And then we see them back and we say, how are you? How's it going? What are your symptoms like? Right. And it's really that, particularly the first appointment with a patient, is a lot of exactly this education and helping them to understand. I try to be a patient advocate as well in this current environment, because so many patients come in and say, I need my hormones tested, doctor. I'll say, well, we can, but let's, depending upon what phase you're in, if you're still ovulatory at all, your hormones are going to change about every 30 minutes. So we don't necessarily need to test them. Let's get your baseline. And then we test to symptoms, right? I tell my postmenopausal patients the same thing is let's define if you're postmenopause, unless it's testosterone, because we don't have FDA approved, we follow hormone levels there, or we're not warning about some other endocrinopathy or hormone producing tumor or something. I'm not talking about the outliers, is really bringing it back to the patient of, unfortunately, like we said, this is social media and a free market, is there's a lot of individuals, businesses that are going to be marketing towards patients to try to make money. And so educating them and empowering them of what really is appropriate and adequate care, what needs to be tested and what doesn't, because a lot of people are getting signed up or prescribed to test all kinds of things on frequent basis that I always tell them, but we treat. And if you look at American College of OBGYN, the Menopause Society, we really treat to symptoms, right? And that's what we keep bringing it back to, is creating this collaborative approach and customizing the approach for you with your HRT.
Yeah. And when you, compare like vasomotor symptoms versus depression, can you help us understand the difference between treating vasomotor symptoms versus depression with HRT? Because studies suggest like HRT can improve the mood primarily when women have hot flashes. So how do you decide like which patient might benefit? Because I know you've been mentioning that over and over because you really like to personalize it.
Yeah. So it's interesting. So if we look at truly studied in the Women's Health Initiative, what are the things that we can improve and what are the risks, right? In the Women's Health Initiative, in these women, the first 10 years post-menopause, right? So from last menstrual period for the first 10 years, we do see a risk reduction in vasomotor symptoms, which for the general population is hot flashes, night sweats, right? We do see a reduction in osteoporosis, and we do see a slight to kind of a gray reduction in neurocognition, Alzheimer's, dementia, right? In patients' reported experience, they also tend to see an improvement in palpitations, joint pain, mood, irritability, some other findings, right? If we start talking about vaginal dryness, that's going to have to be an estrogen that's applied right to the vagina and not systemic. One thing that tends to be pretty disappointing for my patients is we don't tend to see a lot of impact on weight. And there was a couple of really great studies out of the Jacksonville Mayo group that really showed weight implications in the perimenopause, menopause episode has a slight bit to do with hormone imbalance and more to do with human aging and insulin resistance. So that kind of then loops in why I got obesity boarded, right? Because I was like, well, now we have to answer this question. How do we help patients with that, right? So really bringing that in. Now, where is the risk? Because we still talk about risk in HRT. If we're going to do a transdermal estrogen and an oral progesterone, what we see the risk is really in a risk of breast cancer, but we would have to treat 100 women for 10 years to get one increased case of breast cancer. And if you look in the US, this isn't to minimize that, but if you look in the US, our average rate is 12%. 1 in 8 of us is going to get breast cancer. So when we look at that whole together, and I always say this with my patients is, if we're trying to decide, oh my goodness, what do I do? Breast cancer, but benefits, I'm not sure. As you know, in science, there's a data point called a relative risk ratio. And that's where we take all the good and all the bad and we put it together and say, well, what should we do? And the relative risk ratio for HRT in that first 10 years postmenopause is 0.3, meaning it's actually safer. It's closer to 0 than it is to 1. It's actually safer to take it than not in the first 10 years postmenopause. Now, there's ongoing studies. So when we start talking about mood, when we start talking about cognition, there was a study that was done, was the Women's Health Initiative Memory Study. And that was for women greater than age 65. So we're not talking about those exposed women in the first onset postmenopause. These are later exposures. And what we found is actually there was not a reduction in risk in neurocognitive. Actually, it showed an increase of almost twofold. There was a Danish study that was just published in 2023 that was a randomized control trial, again, in this one was in women who were near menopause. The first 3 years post-menopause were exposed to both estrogen and progesterone. And that actually showed only a 25% increased risk in neurocognitive disease. Now, interestingly, in all the observational data, so asking individuals how they feel, in taking small scale samplings of individuals, not a large randomized control trial, all the observational studies are showing same effect or improvement in mood and in neurocognition. So what this says is we need to study it more, right? We need to look at this. And I think what it really speaks to, Deepa, is the multifactorial approach that HRT has is all the different levels. If we're affecting your night sweats that are causing you to wake up 2 to 3 times a night and have, impacted sleep, what do we know about impacted sleep is the downstream effects is higher problems with cognition, higher problems with depression, higher problems with obesity. Is it the night sweats that if we don't treat them as making the worst sleep, and then we treat the sleep and all of a sudden it gets better? It's a multifactorial approach. It brings it back to that thing that we talked about at the beginning, that we are actually ecosystems.
Yeah, makes sense. And then with the Danish study, they were all on the transdermal then?
Yes.
Okay.
Yes. Yeah.
So when there is estrogen variability and mood, how does that play a role, especially perimenopausal mood symptoms? So we do have research now that suggests fluctuating estrogen levels rather than just low levels can contribute to depression.
Exactly.
How does this inform your approach to HRT timing and formula?
Yeah. So let's even take it out of the perimenopausal state. Let's just think about a normal reproductive aged individual, right? There's 2 primary phases to our menstrual cycle. There's something called the follicular phase. That's usually the first 12 to 14 days of a cycle from the first day of your period until you ovulate. And that's when you make follicles or you make eggs. And in that production of making an egg, you are estrogen dominant. That's usually when we feel great, right? We feel good. We got more energy. And then what ends up happening is we ovulate around day 12 to 14. Boom, this little egg pops out of the follicle, and those corpus luteal cells convert from forming estrogen to forming progesterone, and it forms what's called a corpus luteal cyst. And that corpus luteal cyst stays functioning for about 12 to 14 days in most of us. And then it kind of tires out unless it senses there's a pregnancy, and then it takes over for about 10 to 12 weeks. So the first part of our cycle is estrogen dominant, and the second part of our cycle is progesterone dominant, right? So what happens when we're progesterone dominant in a normal, regular menstruating female? For a lot of us, those 5 to 7 days before our period, we'll say, oh, gee, I don't have a lot of energy. I'm kind of crabby. My breasts feel full and tender. I want to eat not healthy foods, because progesterone acts almost like a steroid hormone. For some of us, these symptoms can become so severe that we can actually get PMS, premenstrual, so before your period, that 5 to 7 days, premenstrual syndrome, or you can get what's called PMDD, premenstrual dysphoric disorder. Dysphoria is a derangement or an irregularity in your mood. So that's where we get moody before our cycle, right? This is how this comes, as women talk about, like, oh, I must be getting my period, I'm so crabby. Okay, so we know that comes from an exposure to one of the hormones and a vacillation in the hormone, correct? Because think about what we're talking about in HRT. Oh, we help everyone's symptoms and we give them estrogen and most of them progesterone in a constant dose, right? So let's go back to the phases of menopause that we talked about. Remember, most of us can handle that regular green hills of hormone fluctuations up and down. We know how to handle it, or we know what's coming, we know it's going to resolve. For some of us, we do need support and treatment for that PMDD. But now we move into the Swiss Alps, the perimenopause. And so when those hormones fluctuate so widely and broadly, and we become so progesterone dominant and estrogen deficient, and it's very unpredictable, that's where the symptoms start coming in. It's not, our symptoms aren't necessarily just the depletion of hormones in our body. To me, in some ways, I almost don't, I'm not, don't quote me, but in postmenopause, most of us are like, well, my symptoms are just like this. They're crappy and they're just crappy all the time. In perimenopause, you kind of feel like you're going crazy because some days you feel great and then some days you feel just off and then you think you have it together and then it feels like the bottom's falling out. And because the hormones are fluctuating so much, right? So then the approach becomes, Deepa, is do we stop that perimenopausal woman from ovulating? So we shut down the fluctuations and try to keep them steady state, right? Or do we allow their body to continue to ovulate in that real dramatic way with the hormones, but we kind of raise the bar. We raise the floor of the hormones so they don't feel the fluctuation as much. So that's where it becomes that customization of how we approach it. Again, factoring all in, of course, their family history, their primary medical needs, whatever their risk factors are, what's appropriate.
Yeah, that definitely makes sense. And you had briefly touched upon the transdermal versus the oral. You've given us the history about it. But specifically from a mental health outcome, data now shows like the transdermal, the 17 beta estradiol, it actually looks particularly promising for women. So what would you advise clinicians about choosing the right formulation?
We really, I shouldn't generalize the comment, but the vast majority of us really do try to choose transdermal if possible. The risk is lower. Just with venous thromboembolism, we see the results being a little bit better in the lived experience from the patient. And so some of us will still go back in that perimenopausal episode and give oral contraceptive pills to try to blunt ovulation. The issue is that estrogen and progesterone don't quite respond the same way as the transdermal form. And so you're not going to get the same response. Plus, what we mentioned earlier is what we see is in the transdermal form and how it goes through the liver and how our body metabolizes the 17 beta is we actually get a different effect on the sex hormone binding globulin, which then affects how much free hormone is in our body and able to be affected. And so that's like a secondary manipulation of your hormones. And then it actually also affects the availability and the processing of some of our other neurochemicals is what we're seeing. And so, and then on top of it is when you're doing a transdermal dose, it's going to be a much more steady state dose rather than fluctuations every 24 hours from taking it, half-life of medication, excreting it, and then taking it again the next day. So it's much more of a steady state or a common kind of lived experience.
Yeah. So it's like definitely better tolerated. And when we're looking at limitations of using HRT, specifically because you had also rightly pointed out how we're not really seeing that dramatic antidepressant effect like we were hoping. So some studies definitely show benefit with perimenopausal depression. But you clearly also pointed out like the evidence for postmenopausal depression is less clear. So
Yeah,
how do we navigate these nuances with our patients?
I think part of it is we have to have the discussion of here's the published data. The published data is we're not seeing a large fold reduction, right? However, the lived experience with most of my patients when I put them on is they'll come in and they'll say, oh my gosh, my fuse is not nearly as short. I'm so much less irritable. My mood is better. I'm finding enjoyment in things again, right? So their lived experience really is not following data. And I try to kind of parallel that with my patients as when they have PMDD or PMS, we talk about the same thing. We say, hey, when you become progesterone dominant, and that phase is we kind of feel miserable. So if I can help to support that with a little bit of estrogen through that phase of your cycle, or if we choose to go oral contraceptive route to stop ovulation, is we'll oftentimes talk about, hey, stopping the ovulation might really blunt these fluctuations that you're having, and you might like your lived experience better, right? In that perimenopausal episode. And so I really think that either affecting the ovulation or kind of raising the floor on their hormone levels on those low days really helps the perimenopausal population. The postmenopausal population, I'll say the same thing, is the data, the hard science, Women's Health Initiative mental health study, it didn't sort it out, but that's also not the population that we're really looking at. We need more long-term data. I mean, that's the women 65 and older. We need to start looking at what are those women that were exposed pre-menopause, in the perimenopausal episode and menopausally for many years. What is their story with mental health? What is their experience? Do we blunt it more? So looking at that data will be interesting. The second piece is I personally think what I see with my patients is when we start improving so many other aspects of their lives, their mental health gets better, right? Is their joints don't hurt, so they're moving more. They're not having hot flashes, so they're sleeping harder. They're not irritable, and so they're having better relationships with their partners. And maybe we gave them some vaginal estrogen, and intercourse doesn't hurt anymore, right? It's like it's so multifactorial, multimodal. It's going to be a little difficult to separate out 100%.
Yeah. So that's where the shared decision making is so important and getting them involved. But as far as identifying those vulnerable patients, especially during menopause, are there any specific risk factors or characteristics that help predict who will benefit the most from HRT specifically for their mental health?
I tend to find two good predictors that I often ask about is what was your experience during your menstrual life, meaning when you had regular occurring periods and in perimenopause? Did we have PMDD or PMS, right? Also asking around other reproductive mental health, like did you have postpartum depression or postpartum anxiety? And then secondly, do you have any female family members that also struggled with mental health or depression, anxiety around perimenopause or postmenopause? I tend to find that those are very big predictors as to the severity of what they may experience.
So, as far as the cognitive function and dementia, what's the current evidence on HRT's effect on that? Many women, they really worry about the brain fog during menopause. So, what can you tell them about HRT's neuroprotective versus concerns about dementia with late life initiation?
Interestingly, I wish I had more hard data that I can support you with. In the Women's Health Initiative mental health study, actually, the women who initiated HRT at greater than age 65, their relative risk ratio was 2,
Mm-hmm.
meaning it increased the risk of Alzheimer's, dementia, cognitive disease. In the studies that we do show benefit, again, it goes back to that observational studies are the ones that are showing benefit. And they're showing benefit ideally with just exposure to estrogen. The progesterone at this point does not seem to be as protective, and particularly synthetic progesterones. I think it's going to be interesting to watch where that data comes in, because oftentimes we're using progesterone for the benefit of its sleep initiation and more solid, deep sleep. And we know that poor sleep, sleep interruption has higher incidence of mental health and cognitive decline. So again, I think that the story isn't over. I think it's so interesting that patients' lived experience does not seem to line up with what the data is telling us.
Yeah.
And I think that now we're going to be able to give a far larger volume of patients more long-term exposure to HRT, that the data will come out and really be more enlightening as to hopefully aligning what our lived experience is and what the data is coming downstream.
Yeah, that would be really great to have that kind of information for sure. So when we try to look ahead, specifically looking at research gaps that need to be filled and helping us better understand HRT's role in menopausal mental health, what questions should future studies address to help clinicians provide like more of that personalized evidence-based recommendation?
Yeah, I think when we're looking mental health and kind of neurocognitive decline, is we need a much longer longitudinal study. What is basically breaking it up into cohorts of what patients were exposed perimenopausally, so before menopause, and then in the first 10 years post-menopause, and what does their results go to? Look at individuals that really were not exposed before menopause and only had the first 10 years post-menopause. What did their cognitive results go on to? And then more long-term exposure, right? I think those are going to tell us those arms of, is there a difference or a discrepancy of blunting the extreme hormone swings in the perimenopause period versus replacing permanently or replacing postmenopause. We think that there's a lot of neuro and neurovascular re-architecturalization that goes on with that lack of exposure or with persistent exposure to hormones. And I think that's where a longer longitudinal study is going to give us those answers.
Okay. So thank you so much, Dr. Olson. You've given us a lot of great information. Is there anything else you'd like to add before we conclude?
I think my main thing is I want to really offer to the audience, the patients, people who love patients who are going through menopause, is start the conversation. Just start the conversation with your family, your friends, your medical provider of, here's what my lived experience is. Here's what my medical history is. What should I try for right now? And when should we reassess it? So that you don't feel as though you're being told, yes, you must do something, or no, this is not for you, but it can be more of a discussion point, because it's an area, as you've seen, it's not black and white, it's evolving.
Yeah. Anyway, thank you so much. And we hope we can have you in future episodes.
Absolutely. Thanks so much, Deepa.